First on business would be invocation. I don't know if Tom has asked someone prior. I am a vice chair, so I'm filling in just for today. Tom Bird, our chair, had to do something different. So anyway, that's where we're at. So I will give the invocation. Lord, we thank you for this time. I pray that you give us unity centered around caring for folks that are in need of our services. Give us wisdom and discernment to know which direction to go in, and help us to make positive impacts on as many people as possible. Keep us open to constructive criticism, that we're always working towards becoming better. And we thank you for that. I do want to say a prayer for Tom's wife, Rita, that you help her as she recuperates, and thank you for that. And we pray you give us a good meeting. In Jesus' name, amen.
Amen.
Okay, if you would all join me, and we're going to stand and give the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Making note of our mission and vision statement, and we will go now to public comments. And if you have a comment, we limit you to 3 minutes. You come up to the podium, give your name, and let us know what part of the county you reside in, the township or the city. Come on up. We love to hear from you. Before the first person comes up, I want to send out our apologies to anybody who got messed up last Friday due to the fact at the last minute we had no quorum and we didn't know what to do. And I'm sure there are some of you came here and thought, what in the world? There's no fast way to get that message out to people, to the public, So anyway, we're sorry, but now we're open for your comments.
Barbara Lee Van Horsen, City of Grand Haven, and the Momentum Center. Here for a couple of things. First, I wanted to share with you that we have completed our Sierra study with Michigan State University, which was funded by the Blue Cross Blue Shield of Michigan Foundation, and it had really, really good impact in training members in emotional regulation. We're looking at a next step of that, of offering it to the general public. So stay tuned for that. Also wanted to let you know that we're always looking at ways to expand our services. And I've been concerned about our hours. As I've talked here, even last month, we have a very robust schedule, at least 5 days a week. But we recognize that there are needs beyond the work day. And so we're in the process of surveying our members. When we've tried to add evening hours or weekend hours, we just haven't had participation. But we think there's a need there. So if you know of populations, people that we can get our survey to beyond our membership so that we can assess that, please let us know. It's not a good use of funds for us to just offer something without having people show up. So we want to be good stewards, and we also recognize that we believe there's a need. So if you could help us quantify that need, that would be fabulous. The last thing is I want to invite you all to our next town hall. We've launched our series of town halls on mental health. Last month, we talked about mental health and politics. In March, we'll be talking about mental health and religion. We have a wonderful panel of therapists and clergy talking about both the benefits of religion and the damage that religion can cause and how to recover from that. So I do have some flyers. I hope that you will join us to be part of that important community conversation, because as I like to say, if we all work together, we will keep gaining momentum.
Thank you, Barry. Anyone else? You on the phone? Okay, well, there will be another opportunity towards the end of the meeting for public comment, so you will get another opportunity for that. Now we will go to our consent items. I need someone to make a motion on our agenda and our minutes from the last meeting.
So moved.
Motion and supported. All in favor, say aye. Opposed? Motion carried. We will now move to new business. And I am going to ask that our agenda number 10, the financial part, move up to now. Right. Number 6 on our agenda. So Amy, if you wouldn't mind giving us your financial presentation.
So today we're looking at fund summaries for the mental health SUD fund and the millage and grants funds, October 1 through January 31st. As you know, we are experiencing ongoing financial well, the fund summaries kind of summarize that. This is a report that was run February 20th. So I will say, since that time, we received a prepayment from the LRE for Medicaid dollars. So some of the under budget in the revenues has been addressed, and our total net position is in a little healthier position. You'll see, you know, we're kind of testing out this new target percentage based on actuals paid over the, you know, historical actuals paid at this point. So as of February 20th, with a target of 27.7% through the end of January, we were actually at 29.96. So staying within the range, but still showing a slight deficit that we're, you know, continuing to monitor and work through. Millage fund is in a healthy position, and we had a target of 33%. We were at 39% in the millage fund, but a lot of that is due to one-time payments that get made early in the year for some of our contracted services, and that kind of smooths out as we go forward.
Any questions from the board on that? Can I have a motion to accept?
So moved.
Motion and support, all in favor, say aye. Aye. Opposed? Motion carried. And now we go to the carry forward balance, Amy.
So we do have a couple budget adjustments. This is a budget adjustment of a carry forward for our community health worker grant. And it's just an adjustment to move the money from fiscal year 24 to fiscal year 25 in the amount of $175,014.
Okay. Any questions about that position? We have a motion to adjust the carry forward balance.
So moved. Second.
Motion and support, all in favor of the motion, please say aye.
Aye.
Opposed? Motion carried. Now we go to BA2, the CMH System of Care Budget Adjustment. Amy.
So this is an amendment to increase the system of care grant by $33,000. So system of care was a standard grant that we have ongoing with to increase funding for a couple positions that are being added, or one is being upgraded on a new position for mental health clinician that would operate within this grant.
How large is that system of care budget?
The system of care total is, we have a match, and the total grant is $323,000. It's increased to $356,000 for this fiscal year. It's a 4-year grant, and we have a 33% match annually.
Thank you. So can we have a motion on system of care budget adjustment.
So moved. Support.
Support. Any further discussion? All in favor of the motion, please say aye.
Aye.
Opposed, motion carried. Okay, I think we now go to, let's see, we have no presentation today, but we have our Chief Executive Officer's report. Yes.
Go ahead and continue the rest of that item 10 with the contracts. If you'd like, the
Okay.
amended renewal service contracts and new contracts. So it's still
Okay, gotcha.
Yeah.
So that's you, Michael.
Yeah. So we have, as you know, several months ago, we changed the way that we are reporting the contracts. If it's an amendment or renewal, we have them kind of separated out for new contracts. So the amended and renewal contracts that are in your packet are existing contracts where we're either adding a particular service to that contract
Mhm.
or expanding the scope of service in that contract.
Mhm.
So when you look at the list of amended versus renewal, I'd like to highlight a couple of them and then take any questions on them. So one of the things, if you look at item number 2 under the amendment, one of the things is that one-to-one service in the residential system means that a resident or a consumer requires one-to-one staffing either while awake or around the clock due to serious health and safety concerns or increase in physical care assistance that requires somebody there.
Mhm.
One of the things we're going to have to contend with the board is that every time we write our contracts, we haven't been building in language that also says, and here's the rate for one-to-one if you need it. So this particular contract, we just need to add that because we have someone that needs that service around the clock. You're going to hear later today in my director's report that we annualized are on track to spend over $1 million in one-to-one care for residents in specialized residential care, meaning that in addition to the rate that we give to the provider, the needs of certain residents are so extensive that if you annualize where we're at now, we could spend $1 million on this one-to-one care. I intend to go into that more in depth in about, 20 minutes or so. But that's what that is. You'll also see a series of renewals related to PT Solutions. And this is to expand our capacity. It's renew a contract for OT, PT, speech, behavioral plans. And so without this contract, we would have to hire additional county employees to do a similar service. And right now, I'm kind of in a position freeze on the Medicaid side. So this contract is just adding certain elements to it and our ability to provide the service if we don't have capacity internally. We will have to decide as an organization, as part of our strategic planning, if we need to increase our directly operated staff that are employed by CMH directly to do these services. Sometimes these contracts are needed for people out of county that need this or in county. But really what we're doing is kind of supplementing our directly operated staff with the contract. So this is just expanding it out with certain individuals listed. And you notice like, gee, you could have put it just in one mic and listed them all. And I wanted them to kind of be separated out so you could see the different services we're doing. Make no mistake about it, we could directly operate these services, but we have to do a cost-benefit analysis of the best way to do this. And I'm a firm believer having both options, directly operated and contractual. So these are our renewals to expand out those particular services. The other thing you'll see is item 7, locum tenens, related to psychiatric services. Right now, we have a great doc, Dr. Muhammad, everybody loves him, but he's on a locum tenens contract. And what that means is he's not one of our employees. We pay an exorbitant amount of money for psychiatry infrastructure with this contract. This is to extend it out for a couple of months. It's my intention to not have to use this contract through the year. We should, with a local psychiatrist or our pursuit of finding new psychiatrists, be able to not have to use locum tenens. This is especially true for the DD population where this Dr. Muhammad's primarily doing it. And there are some providers here today and they'll tell you they love the guy. The thing is, it's cost me $500,000. Okay. So we are aggressively looking at to not have to continue this contract after 3 months. The doctor has indicated he may want to come on, but if you hire a locum tenens doctor, there's a huge fee to buy out that. And so I'm just letting the board know it's not my intention to utilize locum tenens contracts for psychiatry services. It's something we should only do if all other options fail. And so I'm aggressively seeking to not have this contract continue after a couple of months. The locum tenens company has been very helpful, very wonderful, but it is an extremely expensive service. So just so you know, we're kind of like renewing that, but it's not the intent to use it for the entire fiscal year.
It's not unusual for a CMH to have to go this route because of the shortage of psychiatrists, not only in Michigan, but throughout the country. It's very, very hard.
Yes. And psychiatrists to me are not just prescribers.
Mhm.
Actually, I think that term's insulting to them.
Yeah.
Okay. They're not just writing scripts.
Yeah.
They help us rule out general medical, physical health conditions as differentiating how you do diagnosis. And they provide psychiatric services that are direly need. So it isn't the quest for a prescriber at any level. I really believe in medical oversight
Mhm.
to help us determine medical necessity for services. So we have to go beyond locum tenens. We have to get that core service stabilized. To me, it's a core. So it's there for renewal, but it's not my intent to utilize the contract throughout the rest of the fiscal year. Just 3 months is what I'm hoping. If you had any other questions related to any of the amendment contracts or the renewal, I'm open to answering those now.
What are the recruitment efforts for psychiatrists that are going on?
Ongoing, never-ending combination of advertising, working with our partners. We just were able to hire that type of service for our family services division and mental health division, not having to use the locum tenens. And we're looking at a way to expand out on that. But it's always a battle to get psychiatrists. But I'll tell you one, and I'm not just saying this because I'm the CEO of Ottawa CMH. Once they come to us, they like us. We have very good retention of the people that we have. And oftentimes they'll come to work for us at less of a cost than they could get in the marketplace. And so just once we find that, our medical director, great at doing this, we're doing fine. But I'm just letting the board know it's not my intention to use locum tenens unless we absolutely happen. No, we just happen to have a really good one right now, but it can't be the long-term strategy. It just fiscally doesn't make sense.
So, any questions related to the contract here?
No, I have a comment though. Can we put the LARA links back in again?
The what?
The LARA links?
Oh, yeah, to look at
What's easier access to get to?
what board member is referencing is the links to see if any of these providers have, like, to LARA, the licensing agency, correct?
Right.
Just to
right.
see
The
if they're gonna-
hyperlink so you can get
Yeah.
to it
Right,
to see what's going on at each
sure,
facility we're approving.
correct.
Okay, so would anybody care to make a motion to, on this service contracts?
I move.
Support. We have motion and support. Any further discussion? All in favor?
It
of the
requires a
motion?
roll call vote.
This requires a roll call.
Yeah, there's
Okay.
finance, yeah.
All right, Miss Amanda.
Yes.
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 Yes. Yes.
Yes.
If new contracts are
Yep.
next, we have one, Mr. Chair.
Yes, sir.
It is one contract for us to purchase training services for infant mental health and what this really is part of our CCBHC program, we have to adopt certain evidence-based practices. Infant mental health is one of them. And so this is a contract for the person to train our staff, and I think it's $3,000 amount,
Right.
so that we can have the professional supervision required to have our infant mental health program. At a future date, we'll do a review of all the evidence-based practices we utilize, and you'll see how extensive the requirements are. We have over 8 evidence-based practices at CMH that the private sector, by the way, does not have to do, that we do, to ensure services are efficacious and meet the best possible quality standards. Part of the CCBHC funding source is a requirement to have infant mental health. This is not new. Infant mental health has been around a long time. It used to be a required evidence-based practice for every CMH, then they changed it and brought it back. And it's providing services literally, like it sounds, from 0 to all the way to 5. And so it's training staff on how to address the issues at that age and manage mental health care. So this contract is just to have somebody provide the supervision that has the right requirement so that we can utilize this evidence-based practice.
I know Stacy Cornett, used to work with her, and she truly is an expert, knows her stuff very well, and we will really benefit from her expertise. With that in mind, may I have a motion to approve this new contract?
Motion.
Motion and support. Any further discussion? All in favor of the motion, please say. Aye. Opposed? Motion carried. Okay, now, where are we at here?
We're at 7.
Michael, right?
Yeah, okay, so many people have to leave by 11. I have a lot to talk about, so I'll be very succinct on that. And I'll be combining items, my report with old business, just so you know. First, I'd like to remind everybody that about 2 weeks ago, we lost a valued member of the CMH team, Veronica Garcia, 30-plus years at CMH in various capacities. Lastly, working with the autism program, providing clerical services and management of that program. Services were last week. And I knew her when I was here last time. And so I've known her for a while. But I just want to acknowledge Veronica Garcia, her tenure at CMH, and a job well done. Her passing was unexpected, and she'll be greatly missed. I will tell you, the Human Resources Department in Ottawa County was amazing. They worked with us hours after we found out around 8 o'clock at night. They had set up stuff for staff to come in, debriefing, grief care. They sponsored a get-together and provided food for our staff to come together and celebrate Veronica at CMH. Scott Hawks, Zachary, that HR department should be commended with the speed, delicacy, and professionalism they handled during this situation. And this department is very grateful to the Human Resources Department at Ottawa County. It made a very difficult situation a lot better. We're proud to be a county department and I was very much appreciative. So I want to let this board know of that. To the staff at CMH that work with Veronica, their eyes are on the ball, but they're hurting, and we'll continually provide opportunities for grief assistance with it. And to Veronica's family, our heartfelt condolences go out to them. So I wanted to start off my report that way. You already mentioned Rita Bird and her recovery, and my thoughts and prayers are with her as well. I've known Rita for, I don't know, 2 decades. So there are 4 general areas of my report I'd like to discuss. And Mr. Chair, with some flexibility, I'm going to be moving in between items 7 and 9. So by the time I'm done with this discussion today, we will have covered both of those items.
Okay.
I want to present today what I'm calling a tale of 2 systems. The Medicaid system and what I call community mental health. Since I've been here, I've made a distinction that we are not just a Medicaid health plan. And the day we become just a Medicaid health plan, we should not only not be a county department, we have to stop calling ourselves community mental health. Even though 90% of our budget, or close to it, is from the Medicaid system, all of the obligations that are in the mental health code still have to be carried out regardless of how the system is funded. I'm going to alert you on a couple of things on the Medicaid side. And then when I'm done with that, I'm going to educate you and orient you to some of the things that we are doing on the community mental health side that make me proud to be a CEO of this particular CMH. So the first part of the discussion is going to be like, oh my goodness, oh my goodness. The second part is going to be like, that's right, this is what we do. So the first thing I'm going to bring your attention to, well, it's not on one of your handouts, is that last Friday, when we were supposed to have our board meeting, the state of Michigan released a press release indicating their intention to bid out or contract out our PHP or regional entity system. If you remember, we belong as a member to the Lakeshore Regional Entity that controls our Medicaid. Mr. Parnham's on that board that represents us. And the state's intention is to have other entities or shrink the number of these entities from 10 to whatever. And they sent out a survey, which I'll be sending out to everybody to look at again and fill out, on feedback and what they think of the PHP system. For you, I want you to think of them as Lakeshore Regional Entity or regional entities. It appears that the state's intent is to once again destabilize the Medicaid system by once again trying to get rid of the Lakeshore Regional Entity. And then somehow like make less of them or have the health plans manage them. This happens every couple of years. Now, there may be merit in changing the system at that level. Remember, they manage the money, ensure that we're compliant with all Medicaid regulations. There may be merit to change the system. However, the process they're utilizing has no feedback from the PHP system or the CMH system. It's simply, we're going to do it. We're going to try to change who is managing the Medicaid system by either shrinking the number of current regional entities from 10 to whatever, or having somebody else do it with the department throughout the state. This process, no matter what you hear in the public or anywhere else, is a 2-year process. So they have to announce their intention to bid it out, which they have. And then once they get applications and they kind of figure out who's going to manage it, they have to give us a year of transition. So we can expect for the next 2 years, absolutely no stability on who is managing the Medicaid money and where the future is going. And I'm already part of a small group that will be talking to state about this. I've been asked to join that. And actually next week, Tuesday, I get to go and talk to certain representatives about this issue. And I will let everybody know which representative it is once we get a final list to talk about the impact of this. So for the public, CMH will be keeping our eye on the ball. We don't anticipate a disruption in service with all of this stuff happening at the next level up, but we will keep everybody educated. In fact, what I'm going to do, and I haven't even told my staff yet, next Friday, I'm going to open up and have a town hall, 12 to 2. We'll get it advertised to anybody that wants to talk about their concerns with federal Medicaid, the state Medicaid, or Medicaid in general because of things happening at the federal level and the state level. I will be there to answer questions, give updates to anybody related to what's going on. I will let this board know that as of today, it could be different tomorrow, there are no plans whatsoever to change the Medicaid waiver program at the federal level. So if that changes, we'll look at the impact of that. But there are no current plans to reduce the Medicaid for the services that we provide, even though an examination of the Medicaid program is being looked at overall. If that changes, I'll keep people up to date on the best I can, but I'm going to hold an open meeting for anybody who wants to come and talk about it. If you have concerns, we have people going to legislators' office saying, what does this mean? I invite folks to come next Friday, 12 to 2, to talk about anything they're concerned about that level. And people can feel free to email me as well.
Has the Board Association, do they have a position on this?
Yes, we have a meeting next Tuesday before this to formulate a strategic plan of action. But it's really about what I'm about to get in terms of the state of our state Medicaid budget. So our board association, the CMH Board Association, was in Washington all this week, meeting with people to find out their stuff. And again, there are no current plans, but anything can change in a day. Just remember, we're in a waiver system. So to change the waiver system, it's very difficult to do. You'd have to do a re-examination of all the benefits or entitlements that are in the Medicaid waiver system, and you'd have to change those things to reduce any cost. So it's a heavy lift to adjust the waivers, the Medicaid waivers that we have. And so I'm not saying it couldn't happen, but I'm more concerned about what's happening at the state level. In your handouts, I have a appropriations key issue document from the Community Mental Health Board of Associations. That's our trade union. And it talks about the different issues that must be addressed in the state. And it gets really confusing. So I'm going to sum it up this way. I'm going to sum it up this way. And then I'm going to walk you backwards to how to interpret these documents. The bottom line is that the state of Michigan has budgeted certain amounts for the CMH system in their budget, in their executive budget. And then the Michigan Department of Health and Human Services has not pushed out all of the recommended budget from the executive budget. They've done this 3 years in a row. Last year, they withheld $120 million from the CMH budgets, gave back about 90 of it, so it still left 40 to 50 they could have given us. This year, and I'm going to show you in a different document, the CMH system, based on the current trending of what we're getting, is going to be short in terms of what was budgeted, over $230 million. So when I talk about Medicaid deficits or ways we have to increase our Medicaid budget because we're not making rates, I am telling this board the money is there. We have to get the state to release the dollars that were budgeted. Now, there's a reason why this can happen. But when you look at this document, I won't go point by point. When you review it, what we're really talking about is what was budgeted, what the department at the state said you actually need, which might be a difference, and then what they actually give us. Simply put, if I'm an advocate and we're going to get people to advocate, the slogan is simple: give us what is budgeted. Keep your promise. Now, if anybody in the state's listening, because you know when they set an executive budget, that's a target. And then each department has to then figure out how much of that budget they're going to push out to the various budgeted items. They determine rates through Milliman. It's an actuarial sound kind of study. This is the stuff I was talking about before. If you have a decrease in Medicaid population, it can change it. And in your packet, you have a document, if you could switch to this, Amanda, that shows you the last 3 years. Fiscal year 23, first yellow column, $4 billion in the executive budget. What did we actually get in the system? 3.7. What did that mean? There was a change in what was budgeted and what was given out by close to 246 million. Now, again, I know there are members of this board that know how budgets work. What I'm telling you is executive budget is the target. The 3 middle columns is all the steps the state goes through, the Michigan Department of Health and Human Services, through actuarial studies to determine how much money they're going to give to each region. To this date, we still don't know all the variables that they use to calculate this. All I can tell you is every region in the state, except for one, has a Medicaid deficit at this point, projected for this year. Out of the 46 CMHs, over 30 CMHs are reporting a Medicaid deficit at this point. This is not an Ottawa County problem alone. This is a system that is not pushing out the money that was originally allocated. So on that handout, you're going to see things like those 3 middle columns. I tried to kind of explain what they are. I call it the Michigan Department of HSS washing machine, an actuarial study. And this is part of budgeting all over the place. It's not abnormal to have an executive budget say one number and end up with another. But I'm going to tell you, when the whole system needs more Medicaid and providers are not being paid what they need to pay, it puts citizens at risk. Give us the money you budgeted. So you're going to hear later today, I have plans to increase rates to residential providers and other providers. It will create a deficit in the Medicaid budget, and I intend to go after the $232 million that's sitting there to help our region and our state pay for it. The money is there. No new money is needed. I want to be clear on that. No new Medicaid money is needed to get us all whole. In fact, I'll be recommending that the state do a cost settlement at the end of the year for every CMH or PHP that has a deficit in Medicaid, especially if this money has not been appropriated somewhere else, which we need to look at. The citizens of Ottawa County and our provider network and our staff needs a Medicaid program that keeps the promise. So I give you the first document from CMHSA. You can read at your leisure and feel free to reach out. But it's really summarizing the table that I'm giving you here. And when I first got this put together, and this was sent to me this week, I was shocked. I did not know this. So any questions on what I'm saying so far? I tried to cover a lot. And again, it was like, right? The money's there.
Do we have any idea why it's sitting there or what has happened to it?
Yeah, the statement from the state, from MDHHS is after us doing an actuarial study and determining the amount of money we're going to give to the region based on the number of Medicaid people and where they're at, we think this is a sufficient number.
So they just changed their minds?
Yeah, it's hard just to change. So like, I want to be very transparent. It's not unusual to have an executive budget say X and then it ends up being Y. In fact, that's part of the process. What I'm saying is because the system is unanimously saying whatever calculations you used isn't correct because we're all in a deficit. We all can't be mismanaging the thing to this degree. If you're over your budget targets by 5, 6, 7%, you get astronomical deficits. So there's been continuous lobbying going on to change this. But now the state is saying, well, we're going to change how we do the PHP system anyway. Right? And I'm afraid they're going to use this as a way to say, well, it's mismanaged. So that's why we have to change it. Well, that means All 46 CMHs and 10 PHPs are mismanaging the Medicaid. It's more likely, Ockman's razor, that there's not enough revenue coming in. The simplest solution is really the best, right? That's the thing that we're looking at here. And because most of our system is a Medicaid funded, this is. So we're putting together, and I'll get the list of the legislatures out that we're trying to meet with. But there's been a full court press to try to address this already. We're going to have to turn up the heat because at the end of this fiscal year, regardless of how many things I try to do to limit this and limit that, we are not going to have enough Medicaid revenue to keep the promise. And it's going to create a deficit. And we're not the only one. So you're going to have to tolerate several months of watching that Medicaid expenditure line going. Why? Because services can't stop. We cannot deny services based on available funding. We can't do it. We have to provide the service regardless of the revenue we get. It's not fee for service. It's not you do a service and you get money. You get the same amount every month to provide as much service as that people are entitled to. We're only serving between 4 to 5.5% of the Medicaid population in our county with the Medicaid we have. Could you imagine if 10% showed up? So we don't even have revenue forecasting models that predict an increase in who receives services at the CMH level. We just say, based on past experience, here's what you get. Here's the number of covered lives you get. Here's your budget. If more people show up, the problem grows. So, tale of two stories. Medicaid, takeaways, plenty of money in the state. All CMHs are struggling. 9 out of the 10 PHPs have a deficit, and the money is there. So the money being there gives me hope that we can get it. And over the next several weeks and months, you'll be asked to assist in advocating for a very simple thing. Keep your promise, give the money you budgeted. To me, it's very simple. Now, there are all kinds of complicated things in the middle, but let's not muddy it. They can do a cost settlement at the end of the year to the public system if the state so chooses to. They can say, all right, here's what our best guess you needed. Here's what happened. Here's what's left. Let's make you whole. And that's the advocacy I'm saying. Make us whole at the end of the year based on expenditures with the money that was already budgeted. And if it's not there anymore, then someone has some explaining to do. And I'll be honest, my almost 30-year career, this seems like a willful and deliberate way to keep money out of for the services for Medicaid to destabilize the PHPs. And that might be a controversial statement, but I believe it. So we're going to have to fight this. So, any other questions of what I'm saying? Did you get the takeaways with that?
You know, I have something, I'm not sure if I'm understanding right, but it seems like the blame is coming down to us instead of the state. Is there anybody that does audits on the state?
Yes. The feds.
Correctly?
They have
Okay.
internally, right.
All right, if everybody's having the problem though, it just seems like common sense
Correct.
that, okay. Just want to note that.
So just a couple of things. The assertion here is that somewhere in a darker closet of MDHHS is a surplus of money that is tagged for CMH that hasn't come through. I also want to kind of point out and make kind of very clear that I'm understanding this. So in pursuit of, the goal, which is to get the funding that we were promised, we are going to accelerate the deficit that we are currently projected to have in the hope that that will make a case that of the viability of your request. I want to make very clear that this is an
Yeah.
open-ended thing that might work out in our favor, and it certainly might not, in which case we will be in a significantly more destabilized financial position than we already are.
Sure.
So I'm all about advocacy. I'll go and talk to whoever you want to in Lansing. That's fine. All day, every day. But I just want us to be very clear that there are two outcomes to this. One is that we succeed and the other is that we don't. And if we don't, we're going to be in a darker spot than we were
Yes.
right now.
Yeah, let me address that. That's a good point. You're going to hear a little bit about me increasing residential rates. Those will go in effect next fiscal year. Okay, so I'm not going to purposely over-accelerate Medicaid deficit expenditures now because I'm already dealing with the increase in utilization of services. What I'm not going to do is stop the utilization of services, but I'm not going to intentionally, at this point in this fiscal year, dramatically increase our Medicaid rate structure to create a deficit, but it will be budgeted next year.
Okay, thanks for that clarification. Super
Yeah.
appreciate it.
Yeah, we have to be smart about it. You have to hope for the revenue, but plan for none. But I intend to send formal notification to the regional entity who will still be in existence next fiscal year, and hopefully forevermore, that our Medicaid expenditure line and our rates have to dramatically increase in certain areas to catch up. So the region may tell me next fiscal year, guess what, Michael? You still have the same amount of money. And then I will have to prioritize our budget based on severity as outlined in our contract and the mental health code. But to our board members' concern, I am not going to make the current position worse by dramatic rate increases right now. But you bet we have to do it by next fiscal year, or we are going to lose our residential provider network. It is that simple, no exaggeration, no drama needed. It is true. And the first thing I did as acting director when I first here was declare a residential services emergency. And I've worked for months with providers to understand what is the current cost of care. In fact, I'm one of the only directors that have met with residential providers besides Lynn before me, but me and this, that have even talked to the residential providers in the state of what their actual true cost of care is. But this CEO is not going to artificially or increase our current deficit trajectory based on rate increases right now. Now, if more revenue comes in this year, sure. Maybe new placements, we can look at a new rate scale coming in, but I'm not going to artificially do that so that oh, guess what? Now we have a $12 million deficit. Gee, we didn't get any revenue. I like my job. So that's the Medicaid situation that we are in. And the documents illustrate that there hopefully is money sitting there, which we believe there is. We have a right to it. We have to make a case for it. And to the Lakeshore Regional entity that I know watches our board meetings, I want to convey to your staff that, and your leader, Mary, who just got a new 3-year contract, you do an amazing job. I'm thankful to be part of the Lakeshore Regional entity. And even though it seems like people have tried for, 10 straight years to eliminate you, you still keep going, you still show up to work, and you are greatly appreciated by this board. Because I know they're watching. They have one person watch the board meetings. Could the system be reformed? Sure, but let's do it in a planful way that doesn't impact the people we serve. Okay, so now I want to shift to something related to rates. And in your handouts, there is a kind of a new rate schedule that I'm proposing for specialized residential.
Attachment A.
Yes, well, there's actually another handout that has some bar graphs that
Okay.
Leah, my Director of Residential Services, is here, help me put together. Hi, Leah. Chris's point, you're going to see that if I were to get all of our current residential services contracts to the rate structure that I think meets the basic cost of care, the difference between what we're spending now and where we need to increase the budget is about 4.6. That's an estimate. That's looking at everybody in our residential system, over 220 people. Okay, what we're currently paying, where they would fall in this 3-level tier system, which I'll talk about in a moment, and estimating the increase. This is what Chris was talking about. I don't intend to put that $4 million on our books right now. But I will tell you, this will be the new rate schedule starting on October 1st, next fiscal year. Without this, we're at risk. I'm not just being drama queen here. We're at risk of losing the residential provider now. So we have 3 tiers. I'm probably the only CEO that's publicly gone over the residential rate system in public and the actual dollar amounts. And I'll have my residential providers, if they like later, see if I'm right on that. I think this might be a first, where a CEO has said in public what the rate structure is. In fact, it's a great mystery for some reason throughout the state, what we pay people. To me, it's simple. So there's a clinical wraparound high-intensity need that can range from $350 to $500 a day. These are residents that require continuous observation, a lot of coordination of clinical services around them in their settings. I call it clinical wraparound. We do not have institutions any longer in the state of Michigan to deal with developmental disability and IDD populations that have high clinical, high behavioral, high physical needs. They no longer exist. In fact, it's now expected that residential providers, to me, are really like treatment providers at this level of care. Since there's no place for folks that need continuous observation, continuous assistance, and they want them in the community, we have to ensure that we're buying models of care, that these homes have a model of care that ensure that all of the physical health and behavioral health high needs are met. It means fluctuating staffing levels without a lot of hassle. Sometimes you say it's a 6-bed home, you need 3 people on. Sometimes you need 4 because something's going on. Plus, the new home and community-based standards we're subject says that say to the providers, you have to get people out in the community, however you define that, several times a week. Well, people need 1-to-1 sometimes when they go out into the community. So our top level is the range of rates, because you base it on individual needs, for folks that need that high intensity clinical wraparound. And in some of my graphs, that's about 99 people we have in our system. We have a pie graph that shows you how many people are in each one of these settings. Specialized residential is residential services or residential group homes that people have said and got a special certification from the state that they can handle person-centered plans, carrying out the goals and objectives of person-centered planning, and can take folks with moderate behavioral and physical health care needs. It's 24-hour care, right? You can see the rate range there. CTH are more like your, we call them mom and pops. A family opens up a residential home. They live there, they sleep there, they provide the staffing, they may have other folks. And we have quite a few people in that level of care. And that's the range we're looking. And so the difference, when you look at the graph, is the yearly, but then you can see, do you know right now we currently, on close to, it's not exact figure, spend about $64,000 a day on residential services. It's far our most expensive thing we do. This increase would move that to $76,000 a day. And you can see the annual group there. So I'm informing you that this is a rate schedule that I intend to utilize and working with residential providers to ensure that this service can, like, who would want to be a residential provider right now on the current rates? Nobody. They lose money. You know, I'm going to many galas for my residential providers. Yeah, I'm going to buy a ticket and sit at, Casey at David's House Ministries or Mocha's or Benjamin's Hope's Gala. You know, the sad truth is they shouldn't have to have a gala to pay for the services that we ask them to do. They should have a gala or a gala, however you say it. My Boston accent comes out with that, to fund additional things, added quality. These providers have to fundraise close to 20% of their operating budget. So yeah, Casey, I'll be at your gala, but you shouldn't have to have one. to pay for the services I asked you to do. This rate schedule gets us to where we need to be, but there's a lot of work to do to find the revenue and adjust the budget, and I intend to spend the next 6 months doing that. I will not add this to our current deficit, but I am projecting it as a budget item for our next budget. And I may implement some of these for new placements this fiscal year, because frankly, none of our providers can take new folks at the current rates. They lose money every day. And I've done due diligence to meet with them for months to prove that. I got the receipts on what they're actually spending the money on. So, you go to Benjamin's Hope, it's a beautiful place, right? And they got animals. Our money doesn't pay for the animals. That's all extra. They have a lot of different things they do for our residents there. That's not what we're talking about. We're talking about the ability to provide services, personal care and CLS. So when I was showing you the first Medicaid thing, I'm showing you there's money. I'm also showing you here's where it's needed, plus other services. CLS and non-residential services I'm looking at now, how to expand that and get that right. So these graphs are just a way to tell you kind of like some of the impact. The pie graph tells you like currently how many people we have in each level of care. What's happening, what I'm seeing is people are needing more of that clinical wraparound than anything else. They need a team of folks working with them in the home. This isn't just somebody renting an apartment somewhere over the boys club. Okay, these are 24-hour care. And we have to treat them as models of care and not base things solely on individual rates for people. It's kind of silly. We do person-centered plan. Well, this one's kind of a lower level, so they'll get this amount a day, and this person will get a higher amount in the day in the same setting. Staff don't go, I'm sorry, I can't help you because you're on tier 2 versus tier 1. I got to help that tier 1 person first, then you. It doesn't work that way. So we got to pay for flexibility within settings to adjust staffing levels without an act of Congress. So that's what this rate structure does. And I base it, by the way, on a living wage for DCWs at $20 an hour with $5 an hour for benefits. I'm doing what needs to be done to protect direct care professionals, direct care workers, to get a wage that is more than what you get at Taco Bell. So my rate structure brings in at least $20 an hour salary and $5 for benefits. And it's just the beginning. There are lawsuits in the state, the law school lawsuit, that wants to pay direct care workers $31 an hour. Okay, fine. If that's implemented across the state, the number I have will double. Fund it, then we'll do it. So this gives you a sense of the impact. It's about $4 million. It could be a little bit more, just depending on who's in what level of care. And it's showing you that we have the majority of our folks in this kind of clinical wraparound model anyways. Here's the other thing. After an exhaustive review of people that have requested residential services and the work with Leah, thank you, and other things, we've built in a prioritization methodology to determine how many folks we think are going to need residential care over the next 12 months, 24 months. We have at least 25 people that we have a 5-star listing. Out of 5, like, need the placement now. That's $3 million. An increase in expenditures. I have it listed in here. We have, I'll get to you right in a second, even more people that we know have aging parents that can't continue to take care of their loved ones. And I'm estimating we could have an estimated 50 people needing placement within the next 2 years. Residential services could become the primary service with the developmentally disabled within 5 years. People are living longer, their needs are complex, and there are no other settings. Nursing homes, don't take them. So I'm projecting not only a rate increase, but an increase in utilization. Donna, sorry, hopefully you didn't lose your thought.
No, that's okay, because there's so much in my head right now. I just wanted to add to the number that you just said. I was going to mention at the end of the meeting, but last month we had the town hall on housing.
Yes.
There was 120 over 120 parents at my meeting that need housing now. It's not 24, 25. And guys, I am
Right.
passionate about this because
Yeah.
I'm really angry right now.
Right.
Everything that you're telling me is making me so angry because I live in these trenches, I work in these trenches, and Sandy was there. She saw all the people there that night.
Right.
Jim, you were there. You saw all the parents there that night that need it now.
Right.
So respectively, guys, thank you for the data. It is more than that.
Of course.
And this whole Medicaid thing right now, I'm just about ready to come out of my seat. I'm so angry at our state and the federal level. You're doing this to parents who are already buried under so much stress. I literally get Jacob's SSI, which is piddly, right, to live on. And I'm sorry, you've been overpaid $1.31. I have
Right.
to send you a check for $1.31. I'm sorry, you've been overpaid 68 cents. What? We get a bridge card for $88 after we've been waiting years to try to get a bridge card. We get 88 bucks. 2 months later, I'm sorry, 44 bucks. Now it's 22 bucks. Well, it costs 10 bucks to get eggs. Now we get 0. So all that money is sitting there. Meanwhile, my 32-year-old son is trying to find a job to
Right.
try to supplement what Sandy Blessed has given us for housing. We can't make that work.
No.
I'm sorry, guys. You don't know me. I feel like I show up to work every day to give my parents hope, to be a light. And this is just making me like, what's the
Right.
point?
Well, the point is, we're going to fix it.
But I don't think I do not think Lansing cares. I
Right.
don't.
But I'll tell
I
you,
do text people and I get crickets back. I'm like, help us.
Right.
And I get crickets. So I don't think Lansing cares.
well,
I am so sorry, guys. I'm just
I will
like
tell you,
filled with emotion.
even the
right now.
numbers I gave you, those are just people that are existing in our system right now. Right? So like the pie chart, it's not even close to the real need. It's how many people now in our system we're thinking we're going to have to do. There are countless others that are on their way. And the housing situation for autism, IDD, has to be looked at comprehensively. And right now, we have to prioritize because this is the Medicaid side, right? For the most severe, which leaves out 3/4 of the population, Donna. So don't you know, we're aware of it. And we're going to keep working at it. And I was just as angry. Now, is this money sitting there in a closet? I don't know.
I don't know.
But I'll tell you what, the time we're done, it's going to be hard not to give us some.
Yeah.
Okay?
The night of our town hall, our guest did such a wonderful job presenting their brother, sister homes, Harmony Communities. Who else was there? I
Right.
can't even remember right now. Doesn't matter. I felt,
Somebody open the door.
oh, Rosalie can't get in.
Oh, well, we try to lock her out every time.
Rosie,
Tried to
Rosie.
keep you out, but
I felt good. You guys did amazing, but I felt so bad for the parents who left there that night, still feeling completely hopeless. And I'm like, I want to give hope so bad, and I don't know how to give hope.
sure. So, understood. One of the reasons the rate increase is needed is the box that's on the screen right now related to one-to-one staffing. Right now, we have certain settings, because we don't have a rate structure that allows them to fluctuate the staffing levels without an act of Congress. They have to request a one-to-one staff, and then we pay a certain hourly rate for that one-to-one staff. My rate structure absorbs some of this cost into it. Right now, annualized with our current people that need one-to-one staffing, it's close to $1 million on top of what people get for their kind of rate, because the rates are so low. So I needed a way to shift some of the need for one-to-one in a more flexible rate schedule. So I intend to reduce the total cost of one-to-ones, especially next fiscal year when we fully implement this, considerably to those that we can. Because right now, they're getting a one-to-one service because we don't have any mechanisms to permanently increase the rate to deal with fluctuations in staffing needs within these homes. Does that make sense? So the new rate structure absorbs some of this cost, but I wanted to show you that with current folks we have on one-to-one level. If you annualize it, this is the number. That wasn't anticipated, right? More and more folks in our system are requiring direct one-to-one care that used to be done in different settings. I'm all for community inclusion and community-based services. You got to pay for it, though. So I only offered you that to say like some of this $1 million one-to-one cost is going to get absorbed up into the new rate structure. Yes, sir.
Thank you. This is extremely enlightening. I guess I'm curious, how did you come up with the $25 an hour rate?
Meeting
Just
with
20.
providers and over months, going over what is the basic, what would be the, what do you need to pay your folks? They actually need to pay a little bit more than that, but we agreed on $20 to start.
Do you know what counties surrounding us pay?
Oh, absolutely. So counties around us, they have the same kind of, they use similar providers. And so they have similar current rates, right? They have similar what they're paying folks, anywhere between $17 and $22 an hour or $15 to $22 an hour. It ranges, but most of our partners have higher Medicaid rates than we do. So they may not have figured it out from an hourly perspective, like in terms of what you're paying folks. But their rates are encompassing kind of that between $17 and $21 an hour range. So we use common providers throughout our region. We have some of the lowest rates per day in our region because we haven't increased the Medicaid rates in a while in a substantial way, where others have. So I built this rate based on the feedback of the provider network and them demonstrating what the need is and staffing ratio levels on that line.
So, sorry, so one other thing that affects then, Jordan, is people become less hesitant to take Ottawa County residents because we pay less.
Yeah, that makes sense.
I know these folks are very dedicated. My question is, what kind of turnover are we having in our residential staff?
Well, luckily for us, with some of our core providers, that's been going down. But in some providers throughout the state, it's as high as 70%. Average is around 40%. We have some that are less than that, some are more than that. The thing is, if I'm working in what we'll call a clinical wraparound program with high intensity needs people, and I'm not able to get paid adequately, it's a tough job to remain in. It becomes, like we're asking DCWs and staff to be like in a mission field. Like they're doing this out of and it's really that bad. I'm not even using hyperbole here. So the turnover rate can be, the national average right now is about 56%, but 70% in some areas for staff turnover.
And one other thing on that too, it is almost a missionary model.
Right.
When we're paying 80% of the need and then they have to go fundraise for the rest of their income.
Yeah, and I may even be overstating the 80%, right? So now listen, all providers are in the same boat in our system. We have to do a triage model. We got to start with residential, then CLS, then but it's not like anybody at CMH that are providing a service is overpaid. So our whole workforce, everybody else, this is an issue that gets compounded. But what I'm telling you is that there appears to be money in the system. So we just need to go and get it. And that's what I intend to do, but I won't overly inflate our budget to prove a point. Right? Because at the end of the day, you got to pay it. Yeah.
I know the state has done direct care worker wage increases.
Yeah.
Does that apply to?
Yes, but it does, but here's the little thing they did this year. Okay, that I didn't even know about. They said they included the direct care worker increase in the rates they gave the region. In the past, they would say, tally up all of the DCW hours that needed a 25-cent raise. What's that amount? We'll cost settle it. This go around, they said, oh, it's already in the rate. And they told me what's in the rate. I've read the 325-page Milliman actuarial study. It points to it, but it can't tell me how much money was actually allocated to our region for this increase. And we've had people in our region saying it's already in your rate, so we don't have to do it. So that is still a hot button issue. Now, the DCW pass-through is to get people to a point above minimum wage. It's minimum wage plus, at this point, $3.20 an hour. So, and it didn't even account the change in the minimum wage that just happened. So if providers are paying more than, say, $18, $19 an hour, technically, the state would say that pass-through is already in there. What I would say is, well, actually, they have to pay their staff that much money regardless of if they think the pass-through amount is in our rates or not. It's still a point of contention that I am working with the regional entity, because I didn't know at the beginning of this year that the DCW pass-through was built in to our rates already from the region.
So you're saying that $232 million shortfall, the state is saying would have been more like 250 if they hadn't included it in, or whatever that number is.
Correct. They already say it's in there. Now, I can't tell you, I read the report and I'm pretty smart reading them. I can't find the line item that says DCW pass-through budget amount to augment what we get in the region. It says it in the verbiage, but none of the tables have it, and I'm trying to find it. Because it's another slap in the face. It's, you're already underfunding us, and now you're saying the DCW pass-through that was approved has to be in the rate already that you get, instead of the state cost settling at the end of the year of that. It's now, we have to manage it. Well, if you're managing a system that's underfunded, it doesn't matter if they put it in the rate or not. If I have a deficit, I have a deficit. So I have to deal with that issue this year, how I'm going to handle that. So on the Medicaid side, you know, we have people delivering services. We have a good provider network. We have to do some recalibrating of things. I'd like to turn, if I could, to the non-Medicaid side. And I'd like to give you some good news. All right? So this board approved at the beginning of the year a second RFP for the use of millage savings. We had one already this year where we awarded social recreation contracts, some other use of millage. And then we did another RFP for other uses of the savings that we had in millage. And we had over 26 proposals. I could have funded, I mean, all of them were valid. We were looking for proposals that deal with some key issues, like housing opportunities, increasing our provider network on the mental health side to bring in certain aspects of mild to moderate mental health and expand our network. We were also looking for proposals that might assist us with the substance use disorder community, bilingual community. And I will tell you, every single proposal we got, 26, I could have easily said we should fund this. I chose 9 to keep the amount of money about $1.1 million, $1.2 million. You had originally allocated about $1.5 million for this, but I want to hold on to some of that millage savings just in case we need to fill a deficit issue with some of it at the end of the year. So I'm holding on to it, or to help in a different way at the end of the year. Or as Amy says, land the plane on the runway, the right runway at the end of the year when we're balancing our budgets. And so you've heard me talk in the past, and I even had a Did You Know series on the CCBHC funding source. This is a funding source that with certain services, we're eligible for an extra supplemental payment. So that's like a fee-for-service model. You do the service and you get some extra money. At Ottawa County, we built the infrastructure internally first, and we haven't really expanded out from CMH to help assist with the moderate mental health populations or other needs the community have. And we haven't really been able to get supplemental income based on those relationships. So the bulk of these people that I've sent award letters to are going to be able to be set up first with millage, but then afterwards have the ability to help us generate supplemental extra revenue on the CCBHC Medicaid side. And again, you need like a degree in MIT to figure all these darn funding sources out. But this is a Medicaid program that allows extra supplemental payments on top of the services you're doing in 9 key areas. So what I wanted to do with this surplus is, let's not just give money for folks to expand mental health treatment and say, good, it should also be able to be set up to generate extra revenue. So by the time we get through it, we'll see if we can generate revenue with some of these folks and not have to use millage in the future. They could self-sustain it. I have one, and so you can kind of see the list of folks that I've given it to. Again, there are many other people that could have been on this list, and we may have to look at later in the year addressing some of those other proposals. But you have like Harmony Communities. They're going to do a housing opportunity to allow autistic folks and folks with IDDE to have support while living in their own apartments and funding kind of like a RA to assist with them. We have to try to find ways to uniquely expand housing options outside of specialized residential. And I'm hoping that this will be the blueprint and that Sandy decides to do 10 more of these, that we can expand residential services to folks that are not currently served by CMH, that have autism, that are in their 20s and 30s, that just need some assistance in a house with somebody checking on them, not doing their personal care, not doing, high behavioral stuff. That's our residential system, but assisting them. So I'm proud to look at that as an option. City on the Hill got the largest award because they have a comprehensive health clinic that I think could be set up as a CCBHC funding machine to help us generate revenue to moderate populations without insurance or crappy insurance as a benefit, as a community mental health benefit. This is the CMH side. Without our millage, we're nothing more than a Medicaid health plan, and I don't want to, that's not community mental health. 70 times 7, focusing on people re-entering from prisons and jails and coordinating mental health services and housing services. Vita Counseling and Wellness, looking at the Latino and Spanish-speaking or Hispanic populations in Holland and throughout the county for both mental health care through the lifespan and social rec opportunities. SOBAR Recovery as a substance use disorder social rec program and peer support that could also eventually be set up, most likely as a CCBHC revenue producer. Community Access Line of the Lakeshore. Our 211 system needs an overhaul. Folks still don't know when you call to it. We need to help develop a database that gets people to the right service at the right time when they need it. This helps the whole county in increasing our ability to access mental health care. Beacon of Hope, increasing our moderate faith-based mental health care system. Mosaic Counseling, increasing our moderate all age spans mental health treatment provisions in our county, and can be set up as a CCBHC candidate, most likely to generate revenue in the future. And then this one's an interesting one. We're going to partner with the Tri-City YMCA to create a social rec program for all population groups in the YMCA with memberships and activities to do to bring our population into a community hub that already exists. This is going to be a pilot program where we're paying per member when they show up. Remember, I told you I'm going to change the funding stream. So I'm giving you this list to let you know that at our next board meeting, which is in a couple of weeks, you'll see an exhaustive description of these in contractual form. And I'll be able to do a better job showing you the rationale for them. But if you did not get a millage award and you did a proposal, they are still at the top of the list to look at. We have some that direly need our assistance, but I have to make sure we use millage appropriately so that we land the plane correctly at the end of the fiscal year. So I'm kind of leaving a little wiggle room, but I intend to maximize our millage benefit because that is the community and community mental health. These things are what the CMH system used to do for general fund that we no longer can do. This is the core of CMH besides our Medicaid program. So I'm happy to say that we're going to invest as a board $1.1 million to increase access to mental health, housing, and social recreation services and substance abuse services through the use of millage. That does not exhaust all of our millage savings that we have in reserve. We still have some left, but I want to hold on to that to deal with any type of funding issues because we can use millage to help fill in the funding issue gaps like general fund used to do. So I have to be prudent of it. But we even had a report from the Healthy Ottawa group that did a needs assessment. And their number one thing was to provide increase in mental health access in the county. And I know Barbara from the Momentum Center, myself, and then Carrie Paranowski are kind of co-chairs of this new mental wellness continuum or task force to address this. And I'm coming out of the gate, and I have a challenge for any other community partner, any person providing services like Corewell Health or anybody else. You go ahead and donate $1.1 million to increase the access to mental health. We can't do it alone. We will do our part. But access to mental health care should be a community issue with all groups trying to find ways to increase capacity. We are investing 1.1 towards that mental health commission based on these things. And I challenge and I will help promote other entities to do the same thing. But that's the community and community mental health. I'll take questions on those. More detail next month.
How much left do we have in reserve?
About $4 million. 3, 8, 4, it fluctuates based on taxable, yeah, so. So that should at least go, okay, that's nice. The Medicaid thing was like, oh my goodness, we're gonna stabilize it. We're gonna go after the money. We're gonna do the right thing. But this board is taking action and trying to address community needs because we're not just a Medicaid health plan. And that was part of a 2-strategy strategic plan that I'm developing, keeping the community and community mental health and being a center of excellence for Medicaid services. And that concludes my report. I'll take any questions.
Thank you. Any further questions?
Not really a question, but I just would say I appreciate the diversity of options here. You know, how you're really looking at a variety of things. And then also the ongoing funding opportunities with them. So thank you for both of those things.
I would echo that.
I believe we're on number 11 of
Yep.
okay. General information, comments, meetings attended.
I'll just, please, guys, I'm a passionate person. So I apologize if I seemed intense, but when you live in that world every day, it's incredibly overwhelming. And when you see young people trying their best with their own cognitive disability or whatever to do their best to be better, it's very hard to know that.
Hard to watch.
Yeah.
I don't know. Anyway, with that said, I do want to tell you that on, what was it? You were going to be there. It was a January night, 27 or something like that. We had a parent town hall on housing, and I was blessed to have Jim from my brother-sister homes, Sandy Baker with Harmony Communities, Matthew from Gracious Grounds, and Agora Flats, which is a housing concept that's in the developmental stages, hopefully to be on Ridge Point Church property. It was wonderful to have all of them share. And then also to seriously know there was over 120 parents sitting in that audience desperately wanting help and knowing that they could get placed tomorrow if they could. And so it was a really great night. We had asked Dr. Brashears to be there to kind of tie all the loose ends together. And unfortunately, he had someplace else he got called to be at. But I just want to share that as that's something that at Compassionate Heart, we try really hard to be a parent resource as well. In the almost 20 years of doing this, just to see the changes. My son is cognitively impaired with autism. I just wanted a place for my son to make friends. That's all I was really looking for, friendships and relationships. And to see in the 20 years how that's evolved into exactly what you're saying, Dr. Brashears. I've had so many more people coming in with one-on-ones because that's not what my staff is able to provide. So just to see the intense and immense changes in people with developmental disabilities and autism has been incredible. I've seen it with my own eyes because the anxieties and the mental status of so many of young people on top of their cognitive disability seems to just been magnified. So that night, listening to parents was heartbreaking, at the same time trying to give hope really trying hard to give hope. But knowing that at Compassionate Heart, every quarter, we try to do some kind of parent town hall, whether it's transitions, special needs, trusts, guardianships, housing, whatever, try to keep parents in the loop because it is really hard to find the information. And I've always kind of maintained that as my son will be 33 on April Fool's Day, my little April Fool's baby. And boy's been playing with my head ever since. Sandy knows him. That truly, the services are out there, but they make it really hard for parents to get it, really hard to get it. And then when you do find it, you're thinking, why should this be this hard? So thank you for all that you do and presenting all this really, really hard information.
Yeah, I just want to speak off what you just said. I was at that meeting that you had there. And I kind of look at it, there's two groups of parents. There's ones that were there that need something right away. They need places for the kids to go, but there's also ones like us who are taking care of our child who's 37. We're aging out and it's just going to become a dire necessity, you know, when we all pass and suddenly you're going to have this influx of more kids. You know, right now we take care of him ourselves and there is no place for him. So he's higher functioning or lower functioning than I'm guessing yours is. He can't be on his own, but there is no place to put him. So it's going to be even more dire.
Just, oh, yes. Bob.
Yeah, I just wanted to say that I had the opportunity yesterday to meet with the MIA Program Supervisor, Michelle Vandershell, to look at the continuum of services on the MI side of things. And I was very, very impressed with the pride and dedication of the staff that work for her. They've been around for a long time. They persevere through some difficult circumstances. But boy, they just keep on going and going. So I just wanted to give kudos to those folks. And
Could you repeat the name, who they were?
yeah, Michelle,
But what's the organization?
oh, the MIA Program Supervisor. So,
Okay.
so
Gotcha.
overall,
people,
those
okay.
programs on the MI side.
Yeah.
And I'm very impressed with the organization and how they're doing. So just a kudos to them.
I just want to say, just like in Christian, that I get a couple times, I don't know, every 3-4 months, I'll get a phone call from someone who has an MI 30-some-year-old adult living in the basement.
Right.
Person, they don't know what to do with them. They can't get them to work. They you know, there's no self-awareness. And they're calling me and saying, what do we do? What do we do with this person? There's a lot of those folks out there that don't hit anybody's radar, right, but mom and dad, you know? So there are a lot of unmet needs in our world. And I appreciate that we're putting budgets in front of people. There's great advocates in front of me, people that care a lot about this. You see the money, the budgets we have. If you got ideas to help us to get to where we want to get, please, Michael's office is open for you. So keep thinking, work with us, right? So anyway, I'm sorry, Christian.
Oh, perfectly good. Thank you. So obviously, over the last quarter, we've, had a number of meetings that have focused primarily on our finances. And I don't want to be the downer, but I would like to point out that the director has, since before the end of the last calendar year, been trying to stand up a finance committee of this board. And I know we're all crazy busy, and we all have stuff that we have to focus on, but, there is the plan to get money from the state. However, prudence merits that we need to form a committee to plan to handle how that might look, or if that doesn't happen. So I would encourage everyone, I've already volunteered to be on this committee and find the time for the people that we serve to stand this thing up so we can start having these conversations, because, that is the other part of our responsibility. We can advocate, we can push the state. However, the nature of the area that we live in is that we sort of look to handle our own problem as well in case the cavalry doesn't come, and that is prudent on our part. So just a suggestion, but it would be really great to get that subcommittee stood up. Thanks.
Good point. So if anybody feels a little tug on their heart, please get to Michael that you'd like to participate in this finance committee.
Nobody wants to cheer it.
Yeah, chair, that's probably the big
That's
issue,
our
right?
problem. Nobody wants to
Yeah,
cheer
yeah,
it.
yeah, yeah, yeah. Okay, we now have,
Kristen saying yes?
It's Christian saying he'll think about it. He's already chairing a couple
that-
boards right now.
is that in the form of a motion? No, I'm just kidding.
Sorry.
No, no, no.
Sorry.
Uh,
Who's not here? Let's make them the
yeah.
chair.
That's how that works.
All right, at this point, we want to move to the final opportunity for public comments. So again, you'll be limited to 3 minutes. Please come forward, give your name and what part of the county you reside in.
My name is Krista Mason. I'm the director of benefits and health and I'm going to talk fast. I have a number of things I'd like to share. First of all, I want to thank you. I will echo what Dr. Custer said. Providers are invited into the discussion in our county. Very grateful. And we are great structure that Dr. Brashear has to individual. I want to echo Donna. I understand. Donna invited me to join the meeting and I struggled. I was out of town.
Yeah.
But I struggled because I didn't do a meeting.
Mhm.
And there's something that is. What our creativity, I think that we can keep out of the county. We get a public private resources to create services. You know, we thank you for engaging us in the process and recognizing that we're talking about models of care. I think one that can do, ask the question or reference, you know, what portion of our cost of care is being covered. From Ottawa County to Richmond, about 70%. So we are presently raising $1.2 million a year that isn't able to go into other essential services for our body. I'm very, very pleased to see the list of millage funded programs that are going to happen. That's the right use of millage funds.
Mhm.
They're not optimal use of millage funds. That's the right for the cost of care that is setting what one is responsible for. Another comment that was raised is the question of wages and why do we pay what we pay, what do we pay? We average paying over $20 an hour for our direct care staff. And they're also receiving benefits in 401k. And they're serving a population of individuals that sometimes, you know, result in injury, right? Or, you know, personal support. So that's the least we can pay them to be competitive and ask them to stay with us. Also, I'd like to talk about the discussion of psychiatric support. And you've heard me talk about this before. I'm Dr. Muhammad coordinator. This week, we had to take an individual to the hospital who needed both medical and psychiatric support. We were told that she should have a medical bed, but we don't have a bed for a person like her.
Mhm. Still out there. Mhm. Wow.
So we've got crisis in our community that does connect to access to psychiatric. Lastly, I'd like to say, I think, you know, when I think about preserving the essential services to the folks who already support, and then hope, you know, being able to serve more people that are presently evaluating this kind of a rate approach is our best hope. Many of us here for being here in a number of years and being able to continue to support them.
Mhm.
Also encourage everybody to fill out the survey that will send out an email from the department about Friday. We might use our call and the consumer providing opportunity to share our concerns with the staff as they consider what they need to structure for our statewide behavioral health delivery.
Thank you very much.
It's not working online.
Oh, it's not? Thanks, Anna. What I sent around to you is a little different than what I've shown you in the past. This is specific to Ottawa clients. So what you'll notice is that the blue line, which represents our revenue coming from Medicaid, has been quite flat for a long period of time. The orange line represents the escalation in cost of care. So
Thank you.
thank you.
You don't want to be wearing hearing aids. Yes, sir.
Good morning. Thank you, Mr. Chairman. Thank you, board members. I'm Greg Coyle. I'm the CEO of the Tri-Cities Family YMCA. I personally reside in Spring Lake Township. The Y is in the city of Grand Haven. I'm also a 37-year YMCA veteran. I'm a licensed clinical social worker. My career began with the Y in New York City as a drug and alcohol counselor in a prevention and treatment clinic. I've dedicated my career to working with marginalized and too often stigmatized populations. I'm here today to speak on behalf of the Mental Health Millage and the presentation that Dr. Brashears just gave. We are excited and honored to be recommended for contracting under the Mental Health Millage funding. As a community-based health and wellness organization serving all ages from infants to seniors, we understand the importance of providing a broad array of programs and services that strengthen the emotional and social welfare of our entire community. A partnership with CMH will expand social rec opportunities to those with substance abuse disorders, intellectual and developmental disabilities, and mental illness in a way that is destigmatizing, engaging, and effective. One of the greatest opportunities we can offer is community connection. We are really focused on the idea of isolation and loneliness being a contributing factor to mental health awareness and wellness. As a social health and wellness hub serving over 10,000 people annually, we're uniquely positioned to provide services in a way that promotes community integration and hopefully reduces stigma. YMCAs across the country, including ours, are working to implement a preventative model of mental health awareness that increases protective factors, resilience, and healthy behaviors. Through this partnership, we can work together to implement this model in Ottawa County. Thank you to the board and our community for supporting this mental health millage. Thank you.
I'm thrilled. That's great.
Hi, Peggy Drusinga, Harbor House Ministries, Jenison, Michigan. I want to thank Dr. Brashears for the transparency. When you talk about families not understanding the system and navigating the system, when I entered the system with a provider 20 years ago, that was a problem that we were saying this needs to be, and for 20 years, I still have families call, no idea where to go. So even just to, much less to speak about rates, but just to say what services we provide and how you get eligibility and those kinds of things are huge for families. For us as a provider, we serve 32 Ottawa County citizens and that are higher needs. And for over the years, as folks age and as conditions become more complicated, those needs increase. When I started 20 years ago, we were able to look at how do we expand, how do we improve, et cetera, because the rate basically met the cost of care. And that stayed flat, and the cost of care have risen to where it is not hyperbole. My board is looking at, can we survive? Can we stay in operation? Like you, no matter what the funding is, the stability, et cetera, you have to meet the needs of the people who are entrusted to you. I have to do the same. I have to staff those needs and meet those needs regardless of whether I have the money to do so, which eventually becomes unsustainable. So this proposal actually would allow us to operate at costs And to be able to look at how do we expand? How do we bring more people to the table? How do we help our community? Because right now we're just trying to survive. And we want to get to that point where we can come together, shoulders together, and thrive as an organization. I also want to echo a little bit of what Krista has said. Our community medical system for the men and women that we serve is not the open door that it should be. When I have somebody whose needs are surpassing what I can provide, they don't meet the criteria to get admitted to a bed. And there is no safety net. There is no crisis place for a provider to take someone that has surpassed the needs that they can provide. And as you had spoken to, Sylvia, it makes it more difficult to take somebody in Ottawa County. And, there are other counties in the state that do have that access to those services. So I would encourage as a county that we look at that. But I also just want to applaud you as a board that you do know, that you do see the needs, that you acknowledge the needs. And I understand that you are taking some, that you're looking at this financial as a risk, but that you are, it feels that you are partnering with us as providers. And I appreciate that. And I thank you, Dr. Brashears, for your work.
Thank you. Thank you. Anyone else?
Good morning. My name's Casey Kuparis. I'm with David's House Ministries. We are one of your specialized residential providers. We currently contract with 7 CMHs around the state. I just want to applaud you and thank Dr. Brashears, his staff, and the board for the amount of time you guys have actually taken in this discussion today. I can assure you your neighboring CMHs are not doing this, and actually just not even having the conversation. Currently, David's House, over the last 6 years, we have grown from serving 36 individuals in specialized residential to 66 today. It's actually, we've done that really on faith that we're going to survive, because every time we do this, it increases our deficit. Currently, since you guys have been so transparent on rates here, I can share with you, out of our $6 million operating budget to serve those individuals, we operate at a $1.4 million deficit. Our gala is March 17. So, and unfortunately, Dr. Brashears got the last ticket. So, but again, I just want to echo that what's being proposed here today, we're all 66 of my folks served Ottawa County residents. I too would be able to operate at cost. And those dollars that we are fundraising could actually be used to continue to expand our services. 30 years ago, when my brother entered the specialized residential world, it was difficult then to find a placement. And now today, 30 years later, myself and my staff are fielding phone calls every single week from families, guardians, supports coordinators from many different counties seeking an opening. And we simply have to say, we don't have any, and we have no idea when we're going to be able to have one. So again, I thank you for the considerations and just assure you that what's being proposed here today would be a difference maker. Thank you.
Thank you.
I'm Jim Gradanis, the Executive Director of the Holland Deacons Conference, and we operate Brothers and Sisters Homes, so 5 adult foster care homes in the city of Holland. On January 15, I had the privilege of attending a Holland City Council meeting where the Human Relations Commission awarded their Social Justice Awards. And we were able to receive an award in the category of housing for the services we provide. Now, I had the privilege of going and receiving the award, but really that award belongs to everybody who supports our organization, our homes, and that includes CMH and that partnership. And we are grateful for that support, and we appreciate the recognition from the City of Holland. It really was nice to bring all of our residents there to see that, and it was a recognition that they're a part of the community, and we appreciate your support, and we join you in, or we invite you to join in sharing that award.
Thank you.
Congrats.
Good morning. My name is Sandy Baker. I reside in Spring Lake, and I'm the Executive Director of Harmony Communities in the Jenison-Hudsonville area. I stand before you with grace and gratitude in my heart for what you do for us, for Dr. Brashears, who comes and visits and spends time with us and listens and hears what we're doing, for all of my colleagues behind me who every day are in the weeds of providing opportunities for people with unique abilities in Ottawa County. We're mothers, we're fathers, we're brothers, we're sisters, we're siblings of who we serve. Thank you for listening to what we do every day and what we try to provide in this county. I think you have behind me, beside me, amazing, wonderful people in this county that are doing amazing, wonderful work every day. But you are as well. And I want you to feel from us in the room our gratefulness for you. Dr. Brashears, I can't thank you enough for all that you've done for us, for your visits that mean so much to us, that raise us up in our present positions in this county. We will continue. I know I can speak for everyone behind me to do our very best, our ultimate every day in what we do. And with your support, we can do even more in this county to work collaboratively and to push this county to the top in the state of Michigan. So thank you.
Thank you.
We have an online.
Huh? We have someone on the.
We'll get to you, Richard.
Rosalie Austin, City of Holland. And it is so great to see the community coming together to talk about the housing crises. And there's just facility crises that a lot of our kiddos do not meet the criteria and are declined. Years ago, my girl was on that list, sent her packet to 30 different facilities and declined. The intensity and severity is only increasing, and guess who has to learn how to do wound care? I'm self-educated on how to meet the needs of my own daughter, that facilities, they try as hard as they can, and I could see the gaps in the care, that they do need more clinical support, but it gets back to basic training of the people who work there too. How do you absorb all that and retain past that 6-month honeymoon phase to keep the job, to really learn your clients, the people served, and not give up? Like, I don't have the choice to give up and discharge, evict, and send on to the next place and kick the can down the road. And it's devastating when we can't meet the needs or aren't meeting the needs, and they're only increasing and increasing, and there's more and more. Where do we go? Where do they live? They're human beings too. And of course, self-directed services is also an option. And the South-D Conference, save the date, May 15th and 16th, Kalamazoo, Seaham. I gotta learn how to do that scholarship application. And yeah, just thank you for all you do in the conversations, and that I'm glad. I have hope.
Thank you, Rosalie. Stephen.
Hi, Stephen Rockman, Grand Haven Township, former board member. Been a very heavy meeting, and I've decided to take a stab at maybe lightening the mood and entertaining. Although I suspect I will be pilloried for being a troubled hater. In the words of J.D. Vance, I don't care, Margaret. So today I'm going to pick up from where I left off on June 3rd with a sardonic rhyme I called Momentum Center and Activism by Dr. Seuss. And I've created a book so you can see the picture. I am the experimenter. I am the experimenter. The experimenter I am. That experimenter I am, that experimenter I am. I do not like the experimenter I am. Do you like momentum center and activism? I do not like it, experimenter I am. I do not like momentum center and activism. Do you like it on Columbus or 7th? I would not like it on Columbus or 7th. I would not like it anywhere. I do not like momentum center activism. You do not like it, so you say. Expose it, and you may. Try and expose it, and you may, I say. Experimenter, if you will let me be, I will expose it, you will see. And he exposes it. Say, I like exposing momentum center activism. I do, I like it, experimenter I am. And I would expose its cultural immersion scam. I would expose the experimenter culturally appropriating in the desert sand. I will expose her and her friends culturally immersing themselves at the bar and the Morocco and the self-loathing civil rights road trips and the drag queens and the CRT. It is so bad, you see. So I would defund it in the millage, and I would defund its grants, and I would defund its momentum, and I would defund its social justice remixed, and I would defund it in Grand Haven and Holland. Say, I defund it anywhere. I do so like defunding momentum center and activism. Goodbye, experimenter. I am.
Thank you, Stephen. Any further? Yes.
Denise Newhouse, Holland Township. I just want to tell you, I appreciate Dr. Bashir's and this board. Things are going better for my daughter, but you know, we have two. We have our son. We can't just have one difficult child. Our son is like the one living in the basement, but he can't be in the basement because it'd be too scary. So he's with us. He's 29, still trying to figure out what we can do, how we can find a place of housing for him. I went to the thing on the HUD housing, but in order to get him something, I would have to drop him off on the streets or the Mission, and that would not work. I'm thinking then APS would get called on me, because he is, you know, he cannot function in the typical, but he's not as severe as others. He's on the autism spectrum, has some mental health issues, and very slow processing speed. So he has that aspect too. He wants to be on his own, and with supports, I think it would work great. So we just need to work on that housing piece. Would be wonderful. Thank you.
Thank you.
Barbara Lee Van Horsen, City of Grand Haven, and the Momentum Center. I just want to invite Steve and the rest of you to engage in respectful conversation. Thank you.
We have someone on the phone. We have someone on the phone calling in. Hello, could you identify yourself and where you live?
My name is David Barnoski, and I vote in
Is there someone on the line?
Port Sheldon Township. Am I being heard?
We tried.
Am I being heard?
Heard something.
Can you hear me?
We cannot hear you, whoever you are.
Can you hear me now?
Yes, we can. Thank you.
Yay.
You are on the clock.
My name's Dave Barnoski, and I vote in Port Sheldon Township. I am a consumer of mental health services recently. I'm pretty happy to find out that I am on the same side as some of the people who I usually oppose in politics in supporting. Can you not hear me now?
We're having some real difficulty right now. Not so much hearing you, but we're getting echoilia.
I'll unplug my headphones. Can you hear me now? Can you hear me now? I give up.
Sorry.
Give up. Let it move on.
Yes. I'm sorry. We don't know what's happening with the system. Please try again.
Move on.
Yeah.
It's still, I think it's an issue.
It's a technician. It's technician.
All these people. Gotcha.
All right, I've hit unmute again. Can you hear me now?
Yes, we can.
All right, shall we start from the beginning? My
Yes,
name's
sir.
Dave Barnoski. I voted Port Sheldon Township. If you can't hear me, anybody raise their hand and I'll know. I have recently become a consumer of mental health service. You can't hear me, can you? I can see it in the face of the commissioners on screen.
Could you try turning the sound down on your computer?
I unplugged it once, but then how do I know you can hear me?
You are echoing.
You're echoing quite a bit. We cannot really
Give up.
understand.
I give up. Move on.
Yeah, just plug it. I publicly apologize to whoever this is. but We cannot. I'm sorry, this won't work.
All right, just you.
Can you just hang them up? Mute.
Oh.
We're echoing.
I'm sorry. If you know this person, please apologize to them for us.
We're echoing.
Anyway,
It's not him.
anybody else in this room?
Yeah, we know. It's something positive.
It's our computer, not his.
Oh, okay, gotcha. I don't know if this is gonna work.
It might just echo the whole time.
Well, we'll give it a go. Carrie? Hello, Carrie?
Hello, can you hear me?
Yes,
Hello, can you hear me?
we can. We'll let you know in a second how well this is going. We're having problems with the sound here on our end. Yes, we can.
You can hear me? Okay. My name is Carrie Vanderveen. I'm the finance director at Heritage, Heritage Homes in Holland. I just wanted to share, I just wanted to share how vital immediate additional funding for our specialized residential program is to the financial stability of our organization.
It's not your fault. It's
like.
You mute the Zoom.
It's our end, we're having problems, but if you would send us an email, and we will take a look at what what your comments are and try to get back with you. It's on our end that there's a problem, not yours. So, appreciate your patience. We do apologize. I don't know how to fix this system. So, we are going to actually, hang up on everybody who's out there. I'm sorry, but please send us an email. We do care. Thank you. Well, that probably sounded terrible.
Oh, you're good. You're good.
Anyway, anybody in the room with a further comment? It's a hard one to follow. Sorry. Okay. Well, we had a robust meeting. Thank you all for participating.